where we're going to put the central ray for the lateral facial bones is going to be a little bit more anterior. So still perpendicular to the image receptor, but it's going to enter, in this case, instead of 2 inches above the EAM, it's going to enter on the lateral surface of the zygomatic bone. So zygomatic bone here, lateral surface right there, opening up your collimation to make sure that you get the temporal portion of the zygomatic bone here all the way out to the nasal bones. All right, so it's going to extend 1 inch or 1/2 of an inch in front of, beyond the tip of the nose. And you don't have to include the vertex of the skull, just superiorly to 1/2 an inch above the supraorbital margins to make sure that you get that frontonasal suture. All right, so again, you're going to look at the mandibular rami, superimposed orbital roofs, and make sure that the cella turcica is in profile, profile being just like a profile on a criminal. It's that side view. Just make sure that your central ray is such that it includes it, but it's also not rotated in any way. So it looks like that. Notice you don't see the base of the skull, you don't see the vertex of the skull. What you do see is from the frontonasal suture all the way back to where would be the zygomatic bone. And they included all of the mandible there, and that's fine. You'd probably want to on facial bones, even if your protocol didn't call for it. So the waters is probably the most complicated view of the skull, definitely the most complicated view of the skull that we're going to talk about today, but it's probably the most important view of the skull, or it's right up there with the most important views. All right, so I'm going to use 2 different skulls to show this. If you remember, whenever we shot a Caldwell, what we have with the Caldwell, what we have with the PA actually is a perpendicular central ray, and it put the petrous ridges, which were right there, right in the middle of the orbits. And if we angled our central ray caudally, what that did was the orbits didn't really move all that much, but the petrous ridges being back here were projected down into the lower third of the orbits. Okay, so what we had was an angulation of the central ray in relationship to the patient. With the waters, what we're going to do is, instead of angling the central ray, we're going to take the patient and we're going to angle their head. All right. Now, the complicated thing about the waters is on the PA and on the Caldwell, our orientation was the orbital-meatal line and the angulation of the central ray. So it was 15-degree caudal angulation to the orbital-meatal line. Orbital-meatal line being perpendicular to the image receptor. But in the waters, what you need to pay attention to is the wording changes. So what we're actually going to be comparing is the angulation of the orbital-meatal line to the image receptor. Okay? So you're going to extend the patient's chin back enough until the orbital-meatal line forms a 37-degree angle to the image receptor. Okay? So if we extended the chin all the way back to where the orbital-meatal line is parallel with the image receptor, we're at 0. Right? We're parallel, so it's a 0-degree angle. So that's 90. So what we're going to do is we're going to have the patient's chin on the image receptor, extend the chin back far enough that the orbital-meatal line forms a 37-degree angle with the plane of the image receptor. And check my time. Good. All right, so what that's going to do is it's going to drop the petrous ridges. Instead of going into the lower third like Caldwell did, it's going to take the petrous ridges, and if we angled the head 15 degrees, then what we would have is basically the same thing that we had with Caldwell, with the petrous ridges in the lower third. But what we're going to do with the waters is we're going to crank the chin back far enough that it's going to take the petrous ridges and it's going to put them below the bottom of the maxillary sinuses. The importance of this is that if we have that blowout fracture, what happens is, again, it's a very thin bone. It's hard to make a diagnosis of blowout fracture, but you can see evidence of blowout fracture. So the patient gets hit in the eye, let's say with a tennis ball, and the eye tries to compress, but it's full of fluid and it can't compress. It blows out the floor of the orbit. Again, it's thin bone, tough to see through everything else that you're shooting, but what's going to happen is, because you've got a fracture there, is the maxillary sinus on that affected side will fill up with fluid and it'll look like sinus infection. So the important thing here for 37 waters is to get the chin back far enough to put those petrous ridges below the bottom of the maxillary sinuses so that we can see evidence of a blowout fracture. You're probably not going to see a blowout fracture for a couple of different reasons. First is the thin bone. And the second thing is, because it's thin bone, and it's pushed down into the maxillary sinus is full of fluid, the thin bone just won't show up. You can't make out the difference between the thin bone and the fluid itself. The other thing is kind of like when we were talking about our hands. If you wanted to see joint spaces, you had to have the joint space perpendicular to the image receptor and parallel to the central ray. So if that joint space is not, if you fail in one of those two ways, you'll close up the joint space. By taking the patient's head and pulling it that far back, look at about that angulation right there. The floor of the orbit is pretty much perpendicular to your line of sight right now. Okay, so that's not a 37 waters. That's what we call a 55 waters. A 55 waters is really good for showing the fracture itself. So sometimes your hospital protocols will call for 2 waterses for orbits. One being 37 waters to show evidence of the blowout fracture that will be fluid in the maxillary sinus, but also a 55 waters, which is going to take the petrous ridges way back here, and it's going to put the petrous ridges in the maxillary sinuses. 37 is going to put them below the maxillary sinus. The 55 waters is going to put the petrous ridges inside of the maxillary sinuses. You're not going to see evidence of blowout fracture, but you might be able to see the fracture itself. So sometimes your orbital series will call for both. I know we're talking about facial bones right now, but for orbits you may have to shoot both.